Hey, Henry, welcome back to the Beyond Relapse Podcast. You look fantastic this morning.
You do as well.
Thank you
You
so
do as
much.
well. But I like this shirt.
So, if I'm not mistaken, this is episode 2, and I need to make an amends here to our listeners, our followers, all 4 of them who listened to the last episode.
And 2 of them are us, you know.
For the 2 people that listened to the last episode, I apologize. I got myself a little confused, and I teased the episode in which we're going to talk about the true cost of treatment, but that's not actually the order. We're not going to be talking about the true cost of treatment today. Today, we're really going to be talking about chronic relapse. And that just makes sense, right? Last episode, we really dove into some of the issues here, the problem, right? Why we're doing this podcast for these families that have been on a long, extended journey of treatment and recovery and relapse. We want to really help them understand how we go beyond relapse, not just focused on their loved one, but for themselves, and how they can have a real life of thriving and joy and happy, joyous and free, as we talk about. So that was episode 1. We are not going to be talking about treatment costs today. We're actually going to be diving really more into what is this chronic relapse. And I think the theme we decided on for today's podcast is when treatment becomes a treadmill. You're working really hard, Henry, but you're not going anywhere.
I'm here.
So maybe, Henry, you kick us off today. Start a little bit, when we use this term chronic relapse, first of all, I understand we're not going to find this term in the DSM anywhere. And in a way, it's a bit of an outdated term, but maybe talk a little bit, what is chronic relapse and this feeling of being on the treatment treadmill?
Yeah, and I was just going to say, we certainly don't intend to use that term pejoratively, right? And some people in our field make a pretty, I think, valid claim that sometimes that can be, a little bit of a shaming label when, these people are really trying to re-engage and engage with recovery. They just have to do so many, many times, right? So we're kind of batting around the term return to use as opposed to relapse. And I don't know if we've found another sort of synonym to chronic, but really all we're saying is that, this person has had multiple treatment episodes and has struggled to meet those markers that we've identified that really lower the risk of meeting criteria for a substance use disorder again, so that first mark of 1 year and then that second mark of 5 years. The person who has engaged in multiple treatment episodes and has struggled to sort of maintain their stability and, sort of a different relationship to substances.
Yeah, that's right. And I appreciate you saying that because I think that's important. And return to use is a phrase that's being used in replacement of relapse at times because relapse can also feel ultimately shaming and it can have this sense that it was all for naught. And everything we did is thrown away. And as we know, and we'll probably talk about today, that's not actually the case. So I've heard return to use. Yeah. I've also heard
it's more complicated than that, right?
It's much more complicated than that, you bet. I've also heard the idea kicked around that rather than chronic relapse, we say sort of continuing to seek sobriety or continuing to seek recovery. And in a way, that's a much more positive framing because when you think about someone who, we're talking obviously about the families who've been on this journey, but also the person of concern, the torment, the hell, the distress that comes with returning to treatment over and over and over again. The fact that someone is still trying, is still seeking recovery, is still putting themselves in a position to get better and to find lasting recovery. On some level, we've got to acknowledge that rather than look at it as just a total failure. It takes a lot to suit up and show up for yet another treatment. So I appreciate you saying that.
Yeah, and we're going to use those phrases interchangeably, and I think it's just important to acknowledge to the audience that there's no connotation of negativity or shame with that.
Yeah.
Right, we're more just speaking to sort of that cycle as it manifests in people's lives. And I've found too, we can kind of underplay and soften the language on something that is also really serious, right?
Yeah.
It's like another return to use can be very, very impactful. And some families don't necessarily relate to the softened language either,
No.
It's like, okay, but we did just take a very big step back that is potentially life-threatening and really serious, So whatever you call it, it's a big deal,
Yeah. Yeah, and it's interesting. You bring up another point. So what is it that we're aiming for, and what takes someone out of the chronic relapse or out of the seeking sobriety phase, the return to use phase? The technical term is sustained remission. So we're looking for, from a medical view, a clinical lens, sustained remission. That looks like a year or more of abstinence in an abstinence-based model. Or if you're in a harm reduction model, it looks like a year or more of not experiencing consequences of use, discontinuing problematic use for a year.
Yeah, no longer meeting criteria.
Yeah,
right.
No longer
DSM.
Meeting criteria.
Yeah.
Say some more about that. What is criteria? When you say meeting criteria, what are you talking about?
Yeah, so in the DSM, the Diagnostic and Statistical Manual for Mental Disorders, when we're diagnosing a substance use disorder, right, there's a handful of different criteria that, when we're diagnosing, we'll look at this person's history, we'll look at this person's current experience over the last 12 months, and we'll be able to determine, whether they meet criteria, right? Their experience falls into those categories, as well as the severity of, the use disorder that they have. So that's what we mean by criteria, right? It's just those characteristics that we've defined statistically as being common among most people with a substance use disorder, right? The common experience that they have. And I confess it's been a little bit since I cracked it open, so I couldn't tell you all. I believe it's 7, right? But, it's loss of job and life functioning, tolerance and withdrawal, inability to sort of moderate you use more than you intended to, or for longer than you intended to, things like that.
Blackout, continued use despite consequences, continued use despite a desire to cut back on use.
Yep.
It's interesting, substance use disorders, I believe, are one of the only behavioral health or physical health disorders where one of the criteria is also someone doesn't believe that they have a problem. The denial aspect. Yeah.
Which is an interesting one. I have a lot of thoughts on that, but maybe we'll save that for another episode.
Yeah. So dive into this experience for families then. So the experience of families, you work with a lot of families, Henry, that are in this quote-unquote chronic relapse zone, the continually seeking sobriety zone, but not hitting that sustained remission standpoint, not getting to that year. These are families that have probably had lots of fits and starts, lots of 30-day, 60-day, 90-day, maybe even some 6 months of success, only then to have a return to use and another treatment episode on the horizon. Talk about the experience of these families and where these families are at, and when they knock on your door and they're coming to meet you and ask you for help. What is it that they're wanting, they're needing? How do you assess what's going on with the family, and how do you start to help them get on a path that hopefully ends in a successful, or I want to say successful, I hate that term, in a more sustained, fulfilled recovery effort? How about that?
Yeah, I think it's a couple of different parts when we're looking at assessment, right? The first thing we're looking at is what's been tried in terms of treatment episodes, the specific. I mean, there are, and I think this is 2022 SAMHSA's data, right? 13,000 treatment centers in the United States. I bet it's way more than that now. Stefan, you might be a little bit more hip to 2025 data, but
I mean, I'm going to look it up right now while you're talking. I'm not sure, but we're going to find out.
There are so many treatment programs. There is some level of shared standards, Joint Commission standards, CARF standards, but at the same time, it really is it's not a very quality controlled industry in many ways, right? And so oftentimes, these families will have engaged in treatment, maybe based on the recommendation of, a family member or friend. A lot of the time it's through Google, and, the best website has kind of won out. And so looking at all these different treatment experiences and first being able to identify, were any of these quality programs, first of all, right? Did they have sort of excellent clinicians on staff? Did they, have the right policies and procedures? Did they address the right things, right? Because as we know, a vast majority of people with a substance use disorder also have some other form of mental illness. And so, did they appropriately address those things? Usually when I think about just on a clinical level, looking at what was missed, right, it usually comes down to, okay, we have some unaddressed sort of trauma, unaddressed or underaddressed, right? I would say a lot of the time it's underaddressed, not unaddressed. Families always want to look to this one sort of traumatic incident that's been repressed or we haven't heard about to kind of be the explanation for everything. But usually it's, the person's maybe done some psycho-ed around trauma. Maybe they've done like a couple EMDR sessions, but not a full protocol, not everything that was needed to really, sort of heal the nervous system. And then we're also looking at, like I said, the mental illness piece. Have we properly diagnosed that and treated that, right? One of the big examples that I think about for people is OCD is a thing that I think about where if you're not addressing that with some very, very specific treatment, very specialized treatment, you will not get better. And sometimes other treatment might actually make it worse, right? And that's just one example, but it's like we're looking at all those pieces, right? What if we not addressed, under-addressed, or tried to address in the wrong way? And then obviously we're looking at length of time. I mean, we talked about last week a little bit about the research that says essentially the longer you're in treatment, the better your odds, right? The more successful you're likely to be. So the 30, 60, 90-day plan, usually without sort of a robust long-term aftercare plan, starting to put our finger on that. And then a lot of where I come in with families is around, the very well-meaning, based on their love and care and fear about their loved ones, well-being, the very well-meaning but ineffective strategies that these families have used to try and get their loved one to change, right?
Yeah.
And at the beginning, I think when people are, families are working through their first couple of treatment episodes, right? A lot of that is just, they don't necessarily have all the information they need, right? Or they don't have the experience with the information to go, okay, that's why we don't buy our loved one a car in sober living and put the title in their name, right? That's why we don't do that, because it resulted in a pretty bad outcome, right?
Right.
This is why when
that car's getting sold, baby.
Yes, it is. Or they're driving drunk in the car and we can't take, there's a lot of situations that occur. That's just one example that has given me some gray hairs.
Right.
I'm a young guy.
Or we, write a check to the school, not put it in their bank account for them to pay the school. There's just little things like that. Yeah.
Exactly. Yeah. And I think common one too is parents who haven't necessarily walked through the resistance that comes with people entering treatment that again, like actually makes really good sense if you think about it. Like we are asking people to give up the one tool that they had in the world to make them feel okay, and we're asking them to give it up. It's like, of course there's resistance and there's a desire to leave and there's all those things. Like I think that's really common, right. But parents haven't necessarily walked through or experienced all the different ways that their loved one is going to try and build a case as to why this treatment isn't going to work, or why, they haven't been fed in 4 days, right? All the ways that they're being mistreated. And so families take that at face value and they trust that. And, that results in some against medical advice discharges that are supported by the family. And then and then the relapse or return to use pattern continues. So a lot of that is just working with the family around sort of preemptively addressing and preparing for some of these challenges that are almost certainly going to come up
right
through the treatment episode.
Yeah, Henry, and you said a whole lot there. We could almost, that there's about 5 different, I think, topics for it could, maybe become podcast episodes in what you said. But ultimately, I think if I was to summarize, and I don't disagree with anything that you just mentioned, but it's first we've got to look at what are the obstacles and what are all the roadblocks that have been getting in the way of somebody. And that's what you were talking about with that really good assessment and looking at what's worked, what hasn't worked. Because what's important is there are some things that have worked prior. If someone is seeking recovery, having a return to use, having a relapse, but they've tried something before, then somewhere in something worked, right? So we've got to identify there are some strengths too, but really assessing what's been tried and what hasn't, or maybe what hasn't been addressed, I think is a way that you said it, right? Those things become obstacles. Trauma can be an enormous obstacle to sustained recovery. And I think the field has gotten much better at identifying and then appropriately and responsibly treating for it. But that's something that's newer. That's a newer addition to substance use disorder treatment. The other thing that you spoke about, and I think that is so important here, is that the families are often uninformed, and because they love and they care so much, that they end up doing things that enable someone, or on some level, even though this is never the intention, support someone in not completing treatment, not continuing on with appropriate levels of continuing care, or ultimately somehow creating ability, giving them access to financial resources that's inappropriate or not helpful for them based on where they're at in their recovery or in their addiction. I think that's really important because our families often talk about feeling so ashamed and so guilty, and there are already a lot of our families coming in feeling on some level that they caused this, and if they would have been better parents, we wouldn't be having this problem to begin with. But then you start to throw in, well, how have you enabled, and how have you, we talked about the dirty E word, we talk about enabling and then lack of boundaries. It can really go into this shame spiral for families. But I think what's important to say is a lot of the things that families are doing are things that any family would do. It's boundaries in addiction treatment for families are counterintuitive. They're often not the same things you would do with a child that's not addicted to substances.
Yeah. I love that you said that, because I think about, I say to families all the time, like, I very much doubt that your dad, right, when you had your child, right, you had your little baby, your dad sat you down and said, this is how you're going to successfully navigate through your son's addiction when he turns 18.
Right.
There was no playbook for this. And it really is...
I didn't even get a tutorial on diapers, Henry, alone.
Well, and it's specialized knowledge, right? It's a specialized illness with specific sort of repeatable patterns that require a different sort of approach and a different way of thinking about, how do we support our loved one in really developing as a person and into a, healthy, independent adult person. It looks a little bit different. And I also kind of point out to families too that, because often it's like the sibling of the loved one is a successful attorney in Los Angeles,
high achieving,
with a wonderful, spouse and two lovely kids, and is very functioning and is doing really well. And it's like, okay, your parenting was really, really effective with that person. They're doing great, but because of this other sort of factor, some of those strategies that worked really well with your other kids may not work so well with this person.
Yeah. You brought up another topic that I want to dive more into, and it was this idea of leaving treatment early or hearing from your loved one in treatment and getting, we call it case building. Yeah. And it's interesting because I think there's a couple of important details here. And one, just for fun, I researched SAMHSA. The most recent data I could find was March of 23, and it's just shy of 22,000 treatment centers in the United States. I think my experience and your experience, not a lot of them are great. Or we should say there's a lot of them that aren't so great. So how, as a family member, do you navigate that? How, as a family, too, when Johnny is calling and saying, this place is terrible? How, as a family member, do you know? Is it terrible? Or is this Johnny's addicted part trying to get mom and dad to co-sign pulling me out of treatment? And you're right. Something we front load with our families at Jaywalker is at the beginning, we have conversations where we say, listen, Johnny's going to call and Johnny is going to say X, Y, Z. Because everybody at some point, I shouldn't say everybody, almost everybody really wants to leave treatment before they're ready to leave treatment. That is such a common experience in an area in which we have to move through in order to get to where we want to go. We have to break through that piece. But it happens for just about everyone, so front-loading the families there. So with 22,000 treatment centers out there, and Johnny's been to 5, and they seemingly haven't worked, how do you help families navigate that? And then how do you help families move through this idea that, I'll tell you a quick story. It's the extreme end of this, but I was with a client who very much wanted to leave treatment because he, on some level was really wanting to use, was really struggling and really wanted to leave treatment. And I happened to be on call that weekend, so I came in and I'm sitting with this guy. He's very escalated, and we're working through and trying to help him regulate, and he really wants to get on the phone with his dad. And I know that, he wants to get on the phone with dad because he wants to try to get dad to pull him out of treatment, but I'm sitting with him, and I make the decision that I'm gonna put him on the phone, and we're going to talk about this, the three of us. So we're on the phone, and the client starts telling dad how we have been attempting to force him to consume motor oil, drink motor oil. And we're on a speakerphone. I'm right in the room with you. To my knowledge, we don't have motor oil on campus. Where did you get the motor oil, right? So, but that's how, and we look at that, and on some level, it's like, well, he's a liar, he's a manipulator, he's all the anger that comes out, and it's justifiable anger. But I look at that and I say, this is in how much distress this person's in. And as he was saying that, and we talked later because he did end up staying in treatment, ended up graduating from treatment. He ended up, this is a really good story, right, with a good outcome at the end. And we ended up talking later, and on some level, he said, I was so desperate in that moment. I knew that no one was going to believe that. I knew that my dad, despite the fact that I'd successfully been able to persuade him to do things in the past that were not good for my recovery, I knew he wasn't going to buy that one. It just came out of my mouth because I was in such a place of desperation. And that's where I think some compassion can come in when our clients are utilizing certain strategies to try to persuade loved ones to do things that are not in their best interest of the recovery. It's because they're in an extreme place of desperation. And you said it, their number one tool, another way that I think about it, is the most important relationship in their life is the one with the substance. Their brain has been rewired through addiction that they absolutely believe the only way that they are going to survive is to be able to continue to use. It's on that level. It's like, I can't breathe. So how do you help families with all that stuff? Johnny calls, they're forcing motor oil down my throat. The food, they're not feeding me. That's the one way we get that our guys will try to get to a lot of their moms, right? They're not feeding me.
Yeah. I haven't met with my individual therapist once.
They're not actually giving me care. I haven't met with my therapist. They're in it for the money, Mom. They're just trying to take your money. That's all they're trying to do here. And you wait, Mom. In a couple weeks here, they're going to be talking to you about aftercare, and that's a money grab, Mom. Don't you buy into it. We're going to do this. We're going to be aligned in this front, Mom, and we're not going to let them steal any more of our money.
You bet. Well, I want to go back to the first question you asked, which is, how do you support families in sort of identifying some real markers to look for what, where is their loved one going to be appropriately sort of taken care of and get good care and get what they need? Because I think that's honestly the first part of the puzzle for a lot of families is
good
understanding and developing some real trusting relationship with the center and with the professionals at the center where, they can have some trust that, there is a different perspective other than the one their loved one is providing them. When I talked about sort of some of the shared standards that we have around good programs, I do think, first of all, about Joint Commission accreditation. I think about CARF accreditation. I think about sort of participation in various professional groups,
National Association,
and things like that. And then really, I think, if you can hire a good consultant and person to kind of help you navigate that, that takes a lot off your plate. You have to vet them, right? So there's still kind of this process, but really, I think it's getting very clear around, what the treatment program is offering, getting really sort of pinning them down around, okay, what is this exactly going to look like? What is the schedule going to look like? Who is this person going to, who is my loved one going to be meeting with? What are their sort of credentials and their experience? Do we have a good, and this is hard sometimes because, we're not infallible, but do we have a good sort of gut feeling about, these providers? Certainly, and I know this is hard for some families that don't want to talk about this in their social circles, but, certainly asking around just people's experience, calling multiple professionals and asking their experience, because most will very kindly, sort of tell you just briefly their experience with that program. If you can visit, I think that's great, or at least get a virtual tour. I think those are all things that families can do to really start to build, just, okay, these people are credible. They do what they say they're going to do. And that can obviously be taken to an extreme end as well, right? Where it's like on some level we do need to take the plunge. And I've worked with families that really have a hard time making that decision around where is my loved one going to treatment, because you could burrow into the details and minutia indefinitely. But I think treating it just like you would any other problem, right? Just looking at the people there. What does the world at large think about them?
Right.
Getting some details. Yeah.
And reputation isn't necessarily Google reviews, which is
I was just going to
challenging.
mention Google reviews.
Yeah. Well, tell the challenge there. I wanted to mention a couple of things that I think are simple tests for me. If I'm a family member and I call a treatment center for the first time that I'm inquiring about my loved one, and the first thing the admissions call center asks me is, what's my insurance carrier? Mm-hmm. That's a red flag. The first thing they should be asking is, tell me about your loved one. Tell me about your family. Mm-hmm. Tell me about things that they've tried. What's worked, what's not worked. Where do you see, you're the expert on your family. Where do you see the challenges? What do you think has been missing? What do you think that they need? Asking questions. They should be asking questions. If the first thing they ask is, who's your insurance? If the second thing they do is just start spitting out a whole bunch of jargon and a whole bunch of modalities that are used. That to me is also another red flag. I also encourage families to ask the treatment center, tell me about your code of ethics and what does that look like and what does that mean for you? Do you have a code of ethics? Is it clearly stated on your website? I also encourage families to ask them about their treatment model. Do they have a treatment model? Do they know what that model is? Can they articulate it? Do they have an understanding of how someone moves through the process of addicted in extreme distress to long-term sustained recovery? I mean, tell me how that moves forward in your facility, in your environment. I also want families to ask not just about the clinical pieces, what is their access to real-world recovery supports? What is their access to aftercare connection and continuing care plans? Really thinking about this, not just, I think what happens often is families and also providers, I think the field ultimately, they're so focused on getting someone into treatment and graduating someone from treatment, they miss the point. It isn't about getting into treatment or graduating from treatment. And that might sound like an insane statement from the CEO of a treatment center. But to me, none of that is all that interesting unless those things lead to long-term sustained recovery. So treatment needs to be in service to long-term recovery, not just graduation from treatment. And that to me is how treatment often becomes a treadmill, is we're so overly focused on getting someone into treatment than graduating someone from treatment. We completely miss the idea that the North Star here is a life of joy, abundance, and meaning in long-term sustained recovery. So those are some things I ask families to ask, because those are higher level questions, and a lot of times reputable, really effective, really competent programs are going to be so excited when you ask them those questions and excited to talk about that. Programs that are really, I call them sort of volume-based insurance mills in a way, right? They're really not looking at quality, they're looking at quantity, trying to put heads in beds, as we say. They're not going to have the answers to those questions, and they're not going to be good answers, and you're going to feel them squirm on the other side of that call when you start to ask about those types of things.
Yeah, great
and then
points.
I can't understate enough what you said. Ultimately, it's why you seek professional help. Because how on the planet can you, as a mom or a dad that has a full-time job and other kids, how could you possibly navigate the landscape of 22,000 treatment centers? And there are people that is their whole world and their whole life and their whole job. People like you who have visited hundreds of treatment centers and have relationships with hundreds, if not 1,000 or more clinicians, providers. You have done this work, and you can do those assessments to make sure that somebody gets placed, because the other thing here is placement becomes so important. If we really want to end this cycle of treatment after treatment after treatment, it isn't just about finding a great treatment center. It's about finding the right great treatment center. Because there are a lot of great treatment centers, but not all of them are the same, and they don't address the same issues in the same way. So really understanding and getting good help, understanding what exactly are those hurdles, those obstacles that have been getting in the way, and what is the right great treatment center. You and I have been worked together for a very long time. We are colleagues. We, hopefully not taking a leap here by saying we greatly trust and respect each other. Most of the clients that you work with don't end up coming to Jaywalker Lodge because they need something else in a different way than we treated at Jaywalker Lodge.
Right. Yeah, and one thing I would add to your very insightful questions that families can ask treatment programs, and I don't hear this question asked very often, but how is your tech staff trained, right? And what support does your tech staff get? Because if you really think about, and that relates to also sort of what is the peer group in the moment at that treatment program.
Right.
But if you think about who is primarily supporting the loved one throughout their treatment journey, it's not the clinicians, right? It's the tech staff. They are seeing the tech staff more than anyone else in any given week in their time in treatment. And talking about that sort of transition to organic recovery engagement, right? That a lot of the time those techs are peers, right? That's a component of sort of the peer support piece, right?
Absolutely.
They're often alumni of the program, alumnus, one of the words, and
alumni.
They have that shared
plural.
Experience. Alumni. And so thinking about that, in terms of, how are they trained in safety protocols, in, sort of the basic CPR, things like that, but also, are they sort of aligned with the values and goals and treatment model, of the institution. And the second thing I said, if we're really trying to get people to connect to a recovery community, can we sort of pair those individuals with a community they might actually connect with, right? So thinking about that.
Yeah, a couple other pieces so first, that's brilliant. Because who are the flag bearers of recovery in the treatment center? It's those behavioral health techs, that direct care staff, that's the non-professional staff, but is with the clients more than any other staff member, and has a higher percentage of personal recovery amongst staff than any other category of staff or department of staff. Those behavioral health technicians who are with the clients at a group in all the activities, those are the people that the clients will be looking up to. Those are your loved one in treatment. It's such a huge point because the behavioral health tech was me, right? A year, 2 years, 3 years ago, they were on their 5th treatment center. They were the ones that were struggling with the chronic relapse. So that's such a great point. You brought up another really good point that I think we need to... There's 2 things that have been buzzing in my brain that we haven't quite addressed yet. And the first one, we've talked around it a little bit, and you just hit it. It's when someone's in treatment, it's pretty easy to be abstinent, sober, discontinuation of problematic use, right? You're inside of a treatment center. There's a high level of structure and accountability. What's in between the clients and their substance use, ultimately, though, is that treatment center. And this is why, another big reason why I think treatment becomes this treadmill is it becomes this transactional experience of going into treatment, staying in treatment, leaving treatment. But because we haven't necessarily had a good connection to an authentic recovery community, because there hasn't been integration, because often aftercare is lacking or continuing care is lacking and doesn't incorporate real authentic communities of care, of recovery, people don't then develop or build recovery capital. they had a good treatment episode and they were abstinent and they did well in treatment, and they probably experienced some reduction of distress, symptoms of depression, anxiety. They probably experienced some reduction of traumatic stress symptoms, post-traumatic stress symptoms. They probably got some good education around the disease, some education around coping skills. They might even in a very simulated. In a simulator, they got to practice some of those skills, right? But they didn't get to test them in the real world out on the streets. So treatment in of itself is largely about a reduction of things. It's about a taking down of triggers, about a taking down of symptoms of distress. It's about learning some things in psychoed. Abstinence happens in treatment, but recovery doesn't happen until you're in community, developing and building real-world recovery capital that you own. It's not transactional, it's relational, it's yours, it's connected to an authentic community. It's not tied to a treatment center that has a start and an end date. Once you're out of treatment, you don't have access to any of those supports or that resource or that structure anymore. So to me, how could treatment not become a treadmill? How could it not be something, if it's done in this transactional way where the only thing in between me and a drink is treatment and then treatment's gone? Why is it that we still look at chronic relapse as an exception? And in fact, it isn't an exception. And I think that's the big piece for today, is this feeling of being on the treatment treadmill of chronic relapse. That's actually the expectation. It is much more common to experience multiple treatment attempts over years than it is to go to treatment once. That hardly ever happens. So anything in any of that, Henry? I don't know.
Well, I think about my own experience working with people, and we've used that word continuity, right? Continuum of care, continuity of care, several times. And I just think about how often treatment episodes have been sort of inherently disjointed, right? And that this person has gone to treatment, they've worked on a handful of things, right? The treatment center may have even been really competent and effective, right? They addressed some of their trauma. They got certain perspectives based on the treatment program's lens of what addiction is and what they need to do. And then there hasn't been a lot of continuity. There hasn't been a robust aftercare plan. They haven't really engaged in an authentic recovery community or really built sort of intrinsic organic recovery capital. And then there's a relapse, and we know that it's between 80 and 90% of relapses happen within 90 days of leaving treatment, right? And then they go to another center where they're told sort of a different slant on how things are supposed to be, what they need to do. They practice some different skills, and then sort of the same thing happens. And if you look at what actually promotes sustained change, right, it's consistency over time, right? It's lifestyle changes over time. It's doing the same thing day in and day out. And that's what builds authentic recovery capital too, is working at the same thing time and time again. And there's so much mixed messaging, right, around what needs to happen for addiction to really achieve sustained remission. So I think about that continuity piece. One of the banes of my existence too is psychiatric continuity. Because I can't tell you how many clients I've worked with that have seen 10 psychiatrists, have been put on meds, taken off of meds, put on the same meds, changed the dosage. They've gone to detox, and detox changed their meds, and then they went to a treatment program. They changed their meds again. We have no real baseline on what actually is going to be effective for this person. And so by the time they come to me, or they come to, Jaywalker or any other sort of longer term program, they're on 10 different meds, and they tell you, I don't know which one of these work, right? I've been on them so long, and we've added so many things. And I think in some ways that's sort of a metaphor for the entire thing, right? Yeah. Which is, I've been to so many different providers, so many different programs. I've been told a zillion things about what's going to work. I'm not sure what works. I'm not sure what doesn't. The only thing I know for sure is that I may not be capable of this thing, right? Yeah. That's a common...
I'm hopeless.
So, like, a lot of our work is actually unlearning a lot of the things that have been taught, or a lot of the things that have sort of been warped through perceived failure, to really get to the heart of, like, okay, here's a simple path that you can walk with consistency to achieve your goals.
Yeah.
regardless of what that is. And I'm not saying there's not utility to being exposed to a bunch of different paths, but I think our messaging is not always super clear, right?
Yeah.
And, we already talked about the aftercare and how important that piece is, but, more than anything, I think it's consistency. It's, real sort of continuity of care to really support that organic recovery engagement.
You bet. So if we were to sort of go along this line, how do we get off the treadmill? How do we make this the last treatment episode, or hopefully the last treatment episode? It started with really good assessment, identifying what's been getting in the way, what hasn't been addressed in the right way. That really good assessment then hopefully leads to a really good placement in a great treatment center that's not just a great treatment center, but it's the right fit for what's going on. Hopefully there's a very robust family component going on in that treatment center that's helping the family system to learn, to understand, to heal, change themselves. Then you brought up this idea of continuity of care. I added there has to be an understanding of how this treatment episode bridges to recovery experience, how treatment connects to real-world, authentic recovery community that allows for someone to build their own recovery capital. So it goes from a transactional treatment episode, rinse and repeat experience over and over and over, to a connection between treatment and the real world of recovery and recovery community, which is the only place that someone can build lasting recovery capital, is in recovery community. And then I think the last thing that you touched on here, which to me might be as important as all of them, is continuing care after care. And unfortunately, most of the people in our country that need treatment don't get it.
Yeah.
Of the people that get treatment in our country, most of them don't move on to a sufficient and appropriate aftercare. And what we know is that continuing care, aftercare, a long-term process is the most important thing that we can do. The greatest predictor of success is time in treatment. And one of the things that I say, and Henry, you can feel free to push back on this, but is if we don't from the start have an understanding that this is going to be a journey of 6 months or more, then we really need to decide if it's the right time to do it. Mm-hmm. If someone is just going to go into a 28-day lockdown treatment episode, and that's all they're going to do, I would almost tell them to save their money. Mm-hmm. What we know is if we can combine at least 6 months or more of recovery support services, I'm not talking about 6 months of inpatient treatment. I'm talking about at least 6 months of a continuum of care that's intentionally and consciously woven together in order to move someone forward, right? Propel them forward in a model to sustained, thriving recovery. That is the answer here. And we know that if we can get 6 months or more of intelligent recovery support services, outcomes all of a sudden go through the roof.
Yeah.
The other thing that we know, and here's the good news about the chronically seeking recovery, chronically seeking sobriety people, is that around 70% of all people with a substance use disorder that engage in care eventually find sustained remission. So that's the real good news here, is despite the fact that it often takes years, on average 8 years, since someone has been diagnosed, someone meets the criteria for diagnosis, 8 years from when they meet criteria to sustained remission. That's a long time. That's a lot of midnight phone calls for mom and dad. Mm-hmm. That's a lot of fear, worry. It's a lot, and we know that. Mm-hmm. It's a lot of trauma for the families. In those 8 years, we're looking at 5 to 10 treatment attempts, treatment episodes, on average. And that's where I said that this is the expectation, not the exception. That's the challenge, right? That's the swamp that we went into in the introduction. That's the place that these families that we're talking to right now, where they're living, right? They're living in this, somewhere in this cycle of 8 years and 5+ treatment episodes, wondering, is it ever going to change? Is this the way it's going to be? Is there hope? Well, the good news is as long as we don't give up, as long as we keep seeking recovery as a family, as an individual, most people find it. Mm. And so I think that's pretty hopeful.
And I'll add, and I want to talk more about the family component of this thing because, I think part of what we've been trying to do with these conversations is to really get at the heart of, the question we just asked, which is, how does treatment become a treadmill and how do we get it off the treadmill? I think there's a lot of things that families can do to improve their relationship with their loved one and reduce some of that trauma or learn how to address it, and cope with it more effectively, even though this is a process. And we're going to have to, and it won't be, despite our total desire for continuity, right, there will be bumps in the road. And there's certainly families can do to work through that and make that easier. So I think next week we're going to talk about what we said we were going to talk about this week, which is cost of treatment.
Yeah.
The true cost.
The true cost of treatment, which is financial, but much more than that. Yeah. Awesome. Thanks, Henry. I enjoyed it.
Yeah, thank you.
Okay.
Absolutely.
We'll see you soon.
Next week.